Good evening. Welcome to the Medical Association of the State of Alabama. My name is Aruna Arora. I'm the president of the Medical Association. And tonight we have special guests to have a discussion to educate us on the updates on uses of monoclonal antibodies. We have, of course, Dr. Harris, our state health officer. We have Dr. David Thrasher, pulmonary ICU physician in Montgomery. We have Dr. Michael Sag, an ID expert out of UAB. And then we have two special guests from the clinical team of HHS that Dr. Harris, if you want to go ahead and introduce for us.
Sure. I'd be very happy to. Good evening, everybody. Thank you for letting us join you. We welcome tonight Dr. Colin Shepard and also Kirsten Henry from the clinical team at HHS. We're very, very fortunate to have them with us. HHS and ASPR in particular has been particularly helpful to us and supportive of us in public health. We recently had a call with them and talked about the possibility of bringing subject matter experts in who could help us answer a lot of questions that you all have with regards to monoclonal antibodies. A lot of new information there about alternative routes of dosing, about other clinical indications. I'll just mention real briefly Dr. Shepard's bio. He is the CDC liaison to ASPR at HHS. He's assigned to support COVID therapeutics. He attended medical school at Wake Forest and completed an internal medicine residency at University of Rochester, has been an EIS officer with CDC and had a number of positions there, including epidemiologist in the Division of Viral Hepatitis. Also the Beijing, China director for HIV/TB programs in China. Additionally, has worked in some other areas, including FDA and New York City Health Department, and a couple of years spent in Ethiopia as well, working on HIV. So terrific ID background. It's going to be great to hear from him today. We welcome Dr. Shepard and also Kirsten Henry as well, and look forward to hearing from you this evening.
Yeah, thank you very much, Dr. Harris, Dr. Arora. I'm very glad to be here talking about COVID therapeutics tonight. I'm joined by my colleague, as Dr. Harris mentioned, Kirsten Henry, who's a ICU nurse practitioner and been in the implementation of COVID therapeutics for some time. I'm going to go ahead and try to share my screen here, and we'll ask somebody to let me know if I stumble along the way. Oh, all right. Host disabled screen sharing. Oh, do you have my slides? Or or should I share my screen?
We do not have your slides.
Hang on
that I'm
one
aware of.
second. Give me 1 second and I'll fix that right up for you, okay?
All right, sounds good.
After a year and a half of Zoom, these things still happen.
Yep, let me try now. Not yet.
Go ahead and just start talking while I get it worked out.
Sounds good. All right. Well, yeah, I'll sort of just start with what I'm going to go through. I'm going to give an overview of monoclonal antibody therapy for COVID-19. I'll talk about some of the recent updates to the emergency use authorization, which is what most of these therapies are operating under at this point in terms of regulatory wise. We'll go over some kind of the specifics of using them for treatment. We'll talk about variants of concern and how those impact selection of COVID therapeutics, and a summary of some of the clinical data that's been coming out and strategies to increase uptake. Would welcome your questions, at the end. This is, these things are new to everybody. We're in a particularly urgent situation now in terms of getting these things to use, into people who need them. We at ASPR have been very impressed with how well work in terms of reducing hospitalizations, and our goal is really to get them to facilitate their use in as many places as possible.
Okay, Dr. Shepard, there you go. Awesome.
Great. Okay. All right, so let me just get right into it. This slide it gives an overview of COVID from the exposure right through to ICU admission, and then where the various therapeutics plug in along that the course of disease. And what I'm going to hone in on is the left side there, which is the early symptomatic period, and then the after exposure. So the monoclonal antibodies for this period, which is before hospitalization, not on oxygen or without an increased oxygen requirement above baseline. There's 3 agents that currently have an emergency use authorization. You can see them listed there. They're bamlanivimab, etesevimab, a Lilly product, casirivimab or imdevimab, a combination product called Regencov, and then sotrovimab. So then just recently, the Regencov has been approved for post-exposure prophylaxis. So the bottom line really with these monoclonal antibodies is that they reduce the relative risk of hospitalization. This has been shown now in phase 3 trials, as well as in some of the operational implementation experience that has been published, and each time it's around 70% of a reduction. So they really do work well. They are for patients with mild to moderate COVID who are at high risk of developing severe disease. And there's a long list of conditions that would confer a high risk, all the ones that you might expect and more. But there's also language in the emergency use authorization that allows for clinician discretion. So even if they don't have any of those conditions, it is left up to clinician discretion as to whether they think there's a high risk of developing severe disease, they can be given. They're most effective early in the disease course. The EUA says within 10 days of symptom onset, but the earlier the better. So in terms of the mechanism for how monoclonals work, there's a few different ways. They all target the receptor binding domain of the spike protein, and some work by blocking cell uptake, membrane fusion, or some tag the cell when it tries to go through the cell wall, tags it for destruction. But they're all on various parts of the spike protein. And at HHS and ASPR and the Assistant Secretary of Preparedness and Response, our goal is really to facilitate the effective use of these agents to reduce COVID-19 hospitalizations, and it's something that's urgently needed now as hospitals in many parts of the country are filling up. So we'd really like to get these out and get them used. We have the federal government has bought an ample supply, and so and they can generally get out to sites within 48 hours. There are 3, as I mentioned, that have been granted an EUA. The one that has been purchased by the government and is available now is Regencov. The second agent there on the right that you see, bamlanivimab, etesevimab, shipment of this agent is currently paused because of its resistance to the beta and gamma variants that were prevalent towards the end of June and July, but have now shrunk to a relatively small proportion. The key word here is paused. We think that it will soon come back into use because it is expected to be active against the Delta variant, which is the vast majority of currently circulating virus. There's also sotrovimab. This is a GSK product that is not available from the federal government, but is commercially available. So let me just mention some of the updates to the EUA that have for these therapeutics that have happened since the first one was issued back in November 2020. The first one for bamlanivimab was subsequently revoked because of viral variants resistance to monotherapy with bamlanivimab. In combination with the same agent in combination with etazevimab was given an EUA in February. There towards the bottom of the slide, you can see that it is active against many variants, not against the beta and gamma, which was why it was paused. The Regeneron or RegenCove received an EUA soon afterwards. It has had 4 updates. The ones I'll talk about in May, it was updated with high-risk criteria for patient selection and added a language allowing for clinician discretion for patients deemed to be at risk of developing severe disease. Updated again with a subcutaneous route of administration as a possibility as an alternative to IV. So this is quite important, especially now as we're trying to get this out to as many folks as possible. It is preferred to be given IV. However, that shouldn't limit its use. In other words, if you're going to lose a patient because the IV route is not available, but subcutaneous is, it should really be given subcutaneously because this is an acceptable way to administer this medication. And then just recently, about 2 weeks ago, not quite 2 weeks ago, it was updated and given an authorization for use as post-exposure prophylaxis. So this was on July 30th. RegenCove was given the EUA expansion for post-exposure prophylaxis. I also want to mention again that it's expected to be effective against circulating variants, including the Delta variant, which is well over 80% of what's circulating now. I've got some links here to additional information that we can make available with these slides and a email address there too, where we welcome any questions that you have. So let me talk a little bit about the post-exposure prophylaxis treatment eligibility. This is the newest part of the EUA. This eligibility for this indication is adults and pediatric individuals 12 years of age or older, weighing 40 kilos or more. This is the same as for the treatment indication, who are at high risk for progression of COVID-19 and are not fully vaccinated or not expected to mount an adequate immune response and have been exposed to an individual infected with SARS-CoV according to the CDC close contact criteria, or who are in an institutional setting where there are some number of cases going on at the same time. So a nursing home where there's a case in at least one other resident. So this is a new authorized use in addition to that for treatment, which is for non-hospitalized patients with mild to moderate COVID in those same that same age range and other criteria. The limits of this authorized use, it's not a substitute for vaccination. It's not for pre-exposure prophylaxis. There is an allowance for repeat dosing for PEP that every 4 weeks for those whose exposure is going to go on longer and are not expected to have an adequate immune response. That repeat dosing is half of the initial dose of 600 and 600, which is can be given by subcutaneous injection or IV. So let me just go over a bit about the treatment eligibility. I think this is where what can really make a difference right now for states that are experiencing a real surge, as I know Alabama is. Treatment eligibility is 12 years of age or older, at least 40 kilograms, mild or moderate COVID, tested positive with a direct viral test within 10 days of symptom onset. So a number of things have to happen pretty quickly, especially if you think about people normally not testing for a day or two after their symptoms, after they experience symptoms and then waiting for the test to come back and so on. It does need to be require some quick action. They should be at high risk of progression to severe COVID-19. But as I mentioned, there's an allowance for clinician discretion there in terms of who's at high risk. In terms of the dosing of REGEN-COV, there is a update to the EUA in just a couple of months ago, allowing half the original dose, which definitely makes a big difference in terms of infusion time. There's also a permission to give this as a subcutaneous injection, as I mentioned before, if giving it as IV would lead to a delay in treatment. It now comes as a single vial co-formulated product that representing one full treatment. So as I also mentioned, sotrovimab is the most recent agent to be given an authorization for mild to moderate COVID-19. It's commercially available. I've got links here to the FDA fact sheet and other and clinical trial information for those interested. In terms of treatment guidelines at the outset, because these were under emergency use authorization and there was not a lot of data out there, they were not included in treatment guidelines from the NIH. They now are, which is a real boost. It should definitely give folks confidence about their use. Currently, it's recommended is REGEN-COV, as you see here, by IV infusion, or if there would be a delay with that route, subcutaneous or sotrovimab. And this is because of the current of the variant composition that as of the latter part of June and July. This may change as now that Delta is the dominant variant, because BAM-EDI should be active against the Delta variant. Treatment should be started, as you see here, again, just as I said, within 10 days of symptom onset. So let me talk a little bit more about variants. Every couple of weeks, the CDC puts out a nowcast, so an estimate of what variants are circulating now based on the data they have, which is which there's a lag, of course, by the time the sequencing is done and the samples get submitted of a couple of weeks. So the most recent one was July 31st. That image is here. The big orange slice there is in the bar to the right is the Delta variant. You can see how quickly that's grown from around 30% and June 19th to more than 80 July 31st. The new estimates will come out tomorrow, and Delta will be higher. So the shipment pause was for BAM-EDI was on June 25th. This is when beta and gamma were quite common. That's being reconsidered, and it may well be allowed to be used again. That decision's not been made yet, but it is likely. For kind of more simple, straightforward of what works against what variant table, I'd encourage you to go to phe.gov /MABS. There is a table there that has the variant, and then on the other side, what it is susceptible to in terms of these monoclonal antibodies. So I'll just mention some of the clinical data. As I said, the phase 3 trials showed a 70% reduction in hospitalization for high-risk patients. There are also some observational studies also showing symptomatic or lower likelihood of developing symptomatic COVID, or the symptoms were less severe. And the, give me just a moment. The most recent article has been on the subcutaneous REGEN-COV for post-exposure prophylaxis, just in the New England Journal of Medicine last week. It did show, this was among household contacts, and it showed a reduced likelihood of developing symptomatic COVID, as well as a lower viral load, which suggests that it is also less transmissible if given early. I just want to mention a couple of implementation studies that have been published. One from the top one there in this table is from Houston Methodist, which implemented monoclonals in a 6-week period across 6 clinics across Houston, treated more than 2,500 high-risk patients. They estimate they avoided about 250 COVID-related hospitalizations. They also collected patient satisfaction data and got a really very positive response, with 99% of patients saying they'd recommend the treatment. So a real excellent example of a successful implementation there that's available to read about in the New England Journal of Medicine Catalyst. Also mentioned the University of Pittsburgh Medical Center implemented monoclonals across a something like 40 hospital network in Western Pennsylvania, was able to get a 25-fold increase since March up until May. So a very brisk uptake there. In terms of the strategies to improve uptake, so one thing I'll mention is that there are the REGEN-COV, which is what's currently available and being shipped, is there's an ample supply. It can be ordered directly from the distributor, AmerisourceBergen. There's no cost for the medication, and there's information on ordering available at phe.gov. In terms of reimbursement rates for the administration of the medication, they were increased a few months ago. They're now, in terms of CMS reimbursement rates, they're $450 for most outpatient settings, $750 when administered in the patient home. So much higher than they were initially, and there's more information that can be found at the links on this slide. So certainly supply should not be a concern. And we encourage you to order what you can use. So, it's our goal in terms of distributing this product to build understanding and awareness of it. This is, never a more critical time than now to do that, as hospitals are getting overwhelmed in so many places. We would really like to make sure that providers are up to date and that patients are aware of their treatment options, because we really think this is a key intervention now for trying to decrease the burden on hospitals and prevent people from getting severe COVID. We provide information on product location through our website and those of our partners. We facilitate product administration and track utilization of the product across localities and populations. Administration of monoclonals can happen in a number of different settings, and we've listed the major ones here. These have all happened, and our team has supported this implementation in these settings. I won't read them out all to you, but they go from home to hospital and a number of places in between. We have a website also, combatcovid.hhs.gov, which has a number of educational materials related to monoclonals. And there's a number of ways that they can be expanded. Of course, it's a challenge if you're treating with an IV infusion product for persons with an infectious disease. This is a challenge known to many who have implemented this. That's why I also want to mention this subcutaneous route as a possibility when IV is not, when there's not the capacity there to give it as an IV infusion. There's also ways to expand capacity in sites and to create the appropriate infection control precautions. This could be a new pop-up center, mobile units, tents, semi-permanent capacity for new brick and mortar locations. We do provide some virtual support for new setups, IT support, administrative support, and then of course patient and provider awareness through educational activities. I'm going to just show you quickly some resources here that will be on these slides that we can make available. Here there are some best practices, some testimonials available there. And there's some excellent videos available of people who have implemented this, including I think some from folks in Alabama quite involved in this. And so I encourage you to look to seek those out.
And Dr. Shepard, just to add to that, sorry, I put in the chat a Regeneron link. They have a great dosing and administration guide, since they're the only ones with a subcutaneous indication. So if you're looking to implement that and you want tools, there's a link to their site, and it's got some good graphics and just step-by-step of how to do the subcutaneous piece if you're looking to train staff on that.
Thank you, that's a great point. We do have a MAB calculator on phe.gov that helps to estimate the operational capacity of infusion sites and to make them more efficient, reduce waiting times. Our office has weekly stakeholder calls and office hours where folks can, on Thursdays in particular, folks can are encouraged to call, ask questions. Kirsten and others of my colleagues are routinely on those and always willing to help out and to really kind of create a community of people who are, can help each other troubleshoot and get these scaled up quickly to as many people as possible. So what we're really hoping is that community leaders such as yourself will promote awareness of these products, so that they can be used by as many people with mild to moderate COVID as possible, and reduce hospitalizations, to know where in your community they can be, they're administered, and then to share experiences to support others. So let me just stop there, and would be glad to take any questions that are out there.
Hey, Dr. Shepard, this is Scott Harris. Could I just start off with a couple of questions? And I apologize if I missed this. I know we want to treat symptomatic high-risk people within 10 days, or ideally as quickly as possible. Is there a time limit for post-exposure prophylaxis? I mean, how long is too long for those patients? And then if I could ask you just one additional question that we received, what about someone who's received post-exposure prophylaxis who subsequently develops symptomatic disease? Is there a reason to consider that additional therapy with a MAB would be useful? Or thank you.
Yeah, and in terms of the post-exposure prophylaxis, there's no limit in the EUA. So that in the clinical trial, it was something like 4 days after diagnosis that they were on average given post-exposure prophylaxis, but there's no stated limit. Now, in terms of it should not, there's no contraindication to getting, if you receive PEP, doesn't disqualify you for getting treatment. Kirsten, you have, I think the half-life of something like 30 days.
It's 28 days because the redosing is at 28 days. So it's a great question, and we can certainly take it back to the product care team to ask if that's been looked at. But I would think if someone gets PEP and develops from that same COVID infection symptoms, then it's, they're in that small percentage of people who are going to go on to develop severe disease or hospitalization, and they wouldn't get redosed within that same disease course. We have seen people who've gotten treated, resolved their infection, and months later gotten treated with monoclonals again because they had a subsequent infection. But for the same infection, symptomatic infection, there's not an indication for redosing.
Dr. Shepard, appreciate that update. Do any of our panelists have any questions? Dr. Thrasher, Dr. Stagg?
No, I think the challenge is, as we've been talking about, is making sure that not just physicians know about this and what to do, but making sure the public knows that if they have any symptoms related to COVID, that could be just a runny nose, sore throat, not feeling well, go get tested early after the onset of symptoms. That's a key message. And if you do test positive, then contact your physician, your provider, and ask about whether you're eligible for monoclonal antibody. So that means that all of our primary care docs should know not only what the indications are, but also where to send people, who to call in terms of an infusion center nearby. That's, I think, the key take-home messages from all of it.
And may I saw a theme through the Q&A questions, just to sort of answer a couple of those questions, because kind of my role is working with the teams that implement on the front lines with some of the federal teams and helping support teams across the country. And the subcutaneous administration, when you read the EUA, IV for symptomatic patients is preferred over subcutaneous, but there was a question about, the time to get somebody in to get infusion. If there is going to be a delay in getting IV infusion to someone who is symptomatic, subcutaneous is absolutely reasonable. So if you're in a region that, it's a long drive to an infusion center, or that your system is overwhelmed right now, is totally based on state regulations who can give the injection. So it does not necessarily require a registered nurse if paramedics are allowed or medical assistants. It's based on what's allowed in your state or your jurisdiction. It is for subcutaneous injections of 2.5 milliliters each. So it's not the most pleasant sounding thing, but when you think of the alternative, it's a faster way to get monoclonals to someone who might not otherwise get them if they can't get to the IV infusion. And to answer the other question that people often ask, which is what do you need to have on hand if you're administering either IV or subcutaneous? What we tell people to think about it in the same terms as you would think about if you were giving vaccine. So having an EpiPen and Benadryl on hand really is kind of what you need to think about. You don't need to have ACLS trained personnel. And when the EUAs first came out, we actually worked with FDA on that to say, we need to be careful what we're requiring so we can get these to more people. So quick call to 911 if somebody's having an adverse reaction, and immediate treatment with an EpiPen, Benadryl, and the rest done at definitive care. So it does not require ACLS and all those things. And if you follow the guidelines for vaccine and what you should have on hand to manage an allergic reaction, then you're doing your due diligence to make sure you could manage a reaction. And somebody asked about Zofran prior to IV infusion. Some patients do get nausea, and what people have found is slowing down the infusion takes care of that. And the rate of severe adverse events has not been, we don't have the exact data, but we're not hearing of significant rates of adverse events with either IV or subcutaneous. And they just published in New England Journal about the adverse event rate with subcutaneous, and it was very similar to placebo. So and no pre-medication. That's another question people have asked. So pre-medication with Benadryl, pre-medication with anything, there's no standard for pre-medication. So sorry, I just wanted to those are the common questions. And I think the goal is some kind of MAB is better than no MAB at all. And it's going to keep people out of the overwhelmed ERs and ICUs. So, if you're in a place that didn't consider it before because you were not able to give IV infusion, it's time to reconsider. I put the email address for COVID-19 therapeutics at hhs.gov in the chat so that if you have clinical questions, we're happy to answer them. We're happy to help support, and phe.gov/MAB has been updated. There's a new playbook in there that's got some detailed information on giving the products, and the Regeneron site is a great resource. So if you're looking to get this going, we're here to help support you. And it sounds like you all have been doing an amazing job, and we're just here to try to help get it to more people as you deal with an overwhelmed system.
Thank you both very much, Dr. Shepard and Kirsten. You're absolutely right. As we're going into the surge and more people are thinking to vaccinate, and if they get infected before they get their vaccinations, this is certainly the option. I'm going to go now to Dr. Stagg and Dr. Thrasher, if y'all don't mind. We have a lot of viewers asking local specific questions to how this can work in our state, and questions on access to the monoclonals and if access is going to improve in our current situation with the surge. Can either of you answer some of those concerns on regional access? I think the question came from someone in Baldwin County. Oh, this is perfect. Yeah. And Mark, you're sharing what I'm seeing now is the list of all the places you can get monoclonals, right?
Aruna, I think that is correct.
It is. This is the list that Mark had sent yesterday. So this is the most up-to-date one that we have currently.
Right.
And can we send this to all our members? Many members who may have these questions on what is the closest center to them.
Yes, we're going to put it in. It might have actually gone out on the email today. I'm not 100% sure on that, but I know we're also going to put it on the COVID page on the website. So we'll make sure everybody has access to that information.
Okay.
Yes, the alert that went out today has a link to this page.
Okay.
So it's in that alert.
Perfect. That is perfect. Dr. Thrasher, did you have a comment you were going to make about that?
Well, just that we have this link, and if patients cannot find a physician in the area, or a physician doesn't know how, they can call the Medical Association of the State of Alabama, and Mark and Aruna will put you in touch with someone who can help you.
Yeah, we can most certainly do that. Okay, there was a question about pediatrics in particular. It's a doctor who says, I have called around for pediatrics. Children's Hospital has not released information on capacity, but it has no formal infusion center currently. When nearly 50 to 60% of kids qualify for service and we currently don't have a place to send them, what can we do? Are there any thoughts on?
Aruna, I would say I don't know about that particular situation. I know that it's really easy for hospitals to be able to do this, even without the public health emergency in place that we had as a state. The CMS blanket waiver is still in place because of the national public health emergency. Hospitals that want to expand into, space that's not normally clinical space we have a really well-oiled machine that can get those waivers approved in about 1 day. And, it's just it's just essentially, life safety type stuff that we just have to do like we would do in any healthcare facility, which we can do really quickly. We prioritize that. So facilities that are already operating as hospitals can add those capabilities really, really quickly. I think what we hear from everyone is that staffing is the problem. And I think that's why a lot of facilities have been slow to have a formal space like that.
Okay. And then there was a clinician who asked, saying that they, by the time they've recognized a patient to have COVID by testing, and then they submit that patient's information for monoclonal antibodies, there essentially is a waiting period. And so then they're getting really close to hitting that 10-day window, So any advice for those clinicians?
Well, this is David. What we do here, and we're not having that trouble in Montgomery. What I typically do, I'll call what I call the monoclonal pharmacist, give the order, then I'll call the contact person at either Baptist or Jackson Hospital and say, this person he's on day 3. We got some wiggle room. Let's get him in the next few days. Or this patient's on day 9. I wanted to do him today. You'll need to have a relationship with the different centers, and the Jackson and Baptist Hospital have been great. They've expanded the capacity. Still not where we need to be, but I plan to work with them in the next day or two about perhaps getting a subcutaneous ward, if you want to call it that, if we just run out of IV options, and we'll try to get them into if Scott Harris can make it legal in Alabama, we could get them in the hands of the rural doctor's offices and urgent cares. That would be huge.
Yeah, I think that's exactly right. The challenge is, again, getting people early enough, and it depends on the site. At UAB, the 2 docs that are doing most of the triaging is Sonia Heath and Turner Overton. And they try to get people in the next day. Sometimes we're socked in. We're doing about 16 IV infusions a day right now. And so if it's going to go out a couple of days, it usually isn't more than a 2-day wait. So that's not really much at play. But I think one of the questions that I saw in the chat that I think is worth talking about just in terms of triage, and that is a fully vaccinated person who gets symptomatic COVID, breakthrough infection, and they are within the 10 days, test positive. We had been doing infusions with them. I'm wondering out loud whether we might be better off doing sub-Q. And the reason for that is that, at least anecdotally, most of the people who are symptomatic with a breakthrough infection after being vaccinated are not getting that sick in general, and especially even showing up in the COVID clinic. So I'm wondering whether a sub-Q, if we're trying to triage to get the people who are most at risk for going in the hospital, which would be the unvaccinated people who are eligible. That might be a way forward to get more coverage. I don't know, Kirsten or Colin, whether you all have had any experience with triage in that kind of way.
I have not heard of that, but I mean, that seems like a reasonable idea to me. Kirsten, have you heard of that being done?
So your idea, actually, I am a fan of, because I've heard other states that are in such situations that they're talking about prioritizing giving any monoclonals to someone who's unvaccinated versus someone who's vaccinated. So I think the idea that, you know, the subcutaneous, doing subcutaneous with those people to still get them monoclonals, but because they're at less risk for severe disease. I mean, it's not called out in the EUA, but it seems like if you had to triage your staffing resources, that would be a reasonable way to consider it and still get monoclonals to everyone, which is our goal.
The one exception I think of is someone who's on chemotherapy, especially if they're on rituximab or something that inhibits B cell production of antibody. If they're transplant recipients, especially liver, solid organ, I think those are the people I'd probably still bring in for IV. But if it's somebody who otherwise, say, is got a higher BMI or diabetes, that type of thing, then that might be something we can consider. But this is all individual decision making.
Yeah, and that's, I think, your idea of, I was considering the fully vaccinated individual. So that person who we have expected to mount a response to vaccine versus the immunocompromised person. Because I agree, I think they're at equivalent risk to an unvaccinated person because we just don't know. So I think that's reasonable. And someone asked in the chat about, you know, if in their area it takes 5 days to get someone in. I think that's really when you start considering, could we implement subcutaneous for the symptomatic people in that area? Because if the system is overwhelmed, you know, subcutaneous is certainly a reasonable option if there's going to be a delay. And the longer we wait, the more chance that people are going to progress to severe symptoms. So, you know, Dr. Red will tell you, as I said earlier, any monoclonal is better than no monoclonal at all. So whatever you can do to not further overwhelm the system, but to get treatment to patients is beneficial.
I guess, Dr. Sag, there was this question about UAB. Is there post-exposure prophylaxis happening at UAB?
Not too much yet. I think we've been focused mostly on the symptomatic folks, but we're in active discussion on that, and so we'll try to keep you posted. But right now, we're not doing that as a matter of course.
Okay. All right. I guess just, you know, as a scenario, if you had a 15-week pregnant female who had COVID, would this be a candidate for a monoclonal antibody infusion? David?
Yes, we actually are infusing some pregnant women right now, and we are seeing a quite an alarming number of pregnant women unvaccinated get COVID. So yes, we're doing that. I'd like to see what Mike's answer was at UAB.
Yeah, we are. That's an important group.
A high risk group, I think. We actually had to take some babies early. These people get really sick if they get COVID.
Yeah. And we've lost a couple of the moms. The babies survived, but not the mom.
And South Carolina is another state, just interestingly, where they're really, Rick Foster, who's with their Department of Health, he's really pushing that and the vaccination in pregnant women because they're struggling with that. One thing I did want to add to the PEP question is one of the things that I think is a really innovative idea is if you've got one patient who's symptomatic and you can get a home health company, you know, if you've got the one symptomatic patient who needs an infusion, but 3 or 4 people in that same house who are high risk, who have been exposed, you can be going and giving, you know, treatment as well as post-exposure prophylaxis to the rest of the household. And you've hit, you know, 5 people at once or however many people without having any of them have to come into the hospital infrastructure. So I know that's 3 steps down the road for all of us as we deal with what we're dealing with right now, but it's something to consider that, we move this more out to the community setting versus the strain being on the hospitals, particularly with the post-exposure.
Kristen, this is great, and I do believe the monoclonals are going to be the solution of keeping our ERs unclogged. But we have to keep pushing the vaccinations. Now, question has come up, and Dr. Saget, I've talked about this numerous times. Somebody had 1 shot, gets vaccine, gets COVID, we infusion. When can you get the second vaccination? I was used to going 90 days, but I think the data that I'm seeing now is 30 days or so. I'd like you and Dr. Shepard and Dr. Sags comment on that. When to get the second or the first vaccine after the infusion?
Yeah, this is a question I, just recently checked in with the vaccine folks at CDC about. They are still recommending 90 days. Wait, as you had been doing. It's based on a theoretic risk, so there, it's not like there's a lot of data behind that. But that is the current recommendation. Kirsten, do you have anything to add on that one?
No, and we found it an additional source. The NIH guidelines also speak to that. So the CDC vaccine guidelines as well as the NIH guidelines speak to the 90 days. So we do not have updated information on that. And the inverse though of if they get vaccinated, which you spoke to, and they end up symptomatic with COVID, they can absolutely get the mAb without any delay in treatment because it's considered a breakthrough.
I know we haven't seen this here in our own state, but I've heard anecdotally of people in neighboring states doing some off-label treatments with the monoclonals. And, for instance, like an 11-year-old who meets the weight criteria, almost 12, things like that. Have you guys started to hear of these situations as you're seeing more pediatric cases?
I have not. Kirsten, have you heard of any of those?
I have not. I know that because it's under emergency use authorization, off-label use is technically not at all allowed. So that's what we have to speak to.
That's good to reiterate here on our medical association webinar. So thank you. Any questions regarding natural immunity that you get, David?
Well, we're asked that a lot, primarily from whether you get the vaccine or not. And Dr. Sagan and I have talked about this a long time. And clearly you have people that have the virus has some natural immunity, some better than others. I've treated 13 patients now that had it twice. I'm treating my first patient that's had it the 3rd time. So you can get it again. And it's recommended that if you have the virus, once you get over it, go ahead and get vaccinated if you have not. We do know that if you get vaccinated on top of having the virus, that's probably the best immunity that we know of. And Dr. Sag has spent his whole career on vaccination, so I'll kick this back to him on that.
Well, yeah, I think what you said is exactly right. The one other thing that comes up a lot, especially with huge amounts of misinformation in social media, is the notion, hypothetically, that antibodies can enhance infection through antibody-mediated enhancement, which there is such a thing as that. But the evidence is going entirely in the opposite direction, where the people who are vaccinated, who have antibodies, are protected against infection. They're protected against advanced disease. And if antibody-mediated enhancement was happening, you would expect the opposite, that people who are vaccinated would do worse. The people who were vaccinated would be more likely to be infected than somebody else. And I'm sure that the question would probably come up again with a monoclonal antibody infusion, where if you're giving antibody and there's a pathogen there that would use that mechanism, they should do worse. And they don't, because that's not at play. So those who are touting that need to stop saying that, because it's confusing to the public, it's confusing to practicing docs. And I just wanted to get that out there so that there's one in particular viral video right now from a guy who's claiming to be an immune expert, and what he's saying is just dead wrong.
Thank you for clearing that up, because you're right. In the next, few weeks, we're going to see patients having to advocate for their own treatments, and get themselves to their doctors or a nearby, urgent care somewhere to get themselves this option. Does anybody have any final comments? I feel like we're approaching the hour here. Well, I want to thank all our panelists today for enlightening us. Dr. Harris, do you have any final comments? I think you're on mute.
Oh, sorry. Just want to say thank you so much to Colin and to Kirsten for joining us. It was terrific and very informative, and we just sincerely appreciate you guys taking time to join us.
But thank you so much for having us. We really appreciate it. We always learn a lot on these sessions, and we appreciate all the good work you're doing.
Yes, thank you for all the work that you guys are doing.
Well, I was going to say the same, and just to kind of give a tip of the hat to you guys, because I work a lot with people at HHS and other places, that you guys are providing a great service to the people of not just of Alabama, but to the entire country. And sometimes you get shots taken at you for no good reason. But what people don't see is behind the scenes, the incredible amount of work that HHS and from my neck of the woods, the HIV/AIDS Bureau and others do. And I just wanted to thank you not only for this, but for all the work you do every day to help keep us healthy and safe.
Thank you so much.
Thank you, everybody.
All right.
Bye.